It's really an honor to be here. It's such a high caliber of clinicians and healers that I've met. I've made some really neat connections with a number of you, and very fast, much more quickly than I typically do. In other circles I float. What I'm going to be covering today is a specific type of EEG biofeedback that uses morphology feedback, where most feedback systems give information on how big and fast various brainwaves are, and ours also gives feedback on the shape of brainwaves as well. And why I created BrainPaint was I had trained over 3,000 clinicians with various types of EEG biofeedback over the years, and most of the clinicians we were training were therapists and counselors, and they're very right-brained, and most of everybody else in my field is very sort of left-brained. And the engineers who had designed the software would make it perfect for engineers. So I don't know if any of you followed Silicon Valley, but how the lead architect of his software made this really complicated GUI, and he had all of his engineers test it, and they all said, it works perfect. And that's what our field was like to a large extent prior to this. So we were, in 1990, I was working on an Indian reservation in northern Minnesota, and Dr. Eugene Peniston's papers came out from like 85, 86, and 89 on alcoholism with people with PTSD. And I laughed and threw them in the trash. It's like, sure, PTSD, veterans with alcoholism, 80% success rate, complete elimination of PTSD symptoms. They no longer met diagnostic criteria. After that, it was completely unbelievable. I just threw them in the trash. And then a program opened up that was offering the service. And on this reservation, I was the addiction specialist. I was in charge of all addiction services, and I'd been referring people to various treatment programs over the years. And after about a 2-year period, I'd referred 160 people to just about every treatment center in the state, some Native American specific, other 12-step programs and things of that nature. And there were only 2 people who were staying sober. Most of it was alcoholism at that time. And they were dying. About every other week, I was attending funerals and things of that nature also. And then a program opened up that was offering this service. And I thought, well, I'll see how good this stuff works, for lack of a better term. And I referred 2 people with it who had real severe character disorders through the program, thinking they're just going to tear this program up like they did everything else. But quite miraculously, they did really well. They actually did better than I think anyone I've ever seen do that number of sessions with that kind of pathology. They did remarkably well. They stayed in treatment. They'd never finished treatment, which is another thing, too, is only 40% of the Native Americans were completing addiction treatment programs, too. 60% would leave against medical advice before it was finished. So these 2 finished and were doing well. So I started referring more people to the program, and I was born a computer programmer also, so I really understood the technology on a much deeper level. I was reading all the papers, and the people who were running it didn't really know so much what they were doing and didn't really feel confident around computers. This was back in the early 90s where you hit a button, the machine's going to blow up, or you're going to launch World War III or something like that. Everyone was really frightened of them, and I wasn't. And so they were trying to recruit me, and after I think I'd sent 5 or 6 people only through the program, but they were all doing really well. They were all completing treatment. They were all working their step work in the program. Those who had gotten out were going to 12-step meetings and things like that afterward. So ethically, it's like, what am I going to do? Sit here and attend funerals every other week, or get involved in this new field? And so I accepted that position in 1993. And then in 1995, I'd hooked up with Dr. Eugene Peniston. Prior to that, we'd ran 24 Native Americans, or 27 through that particular methodology. Ended up with a 79% success rate. We were able to contact every individual and others who verified their abstinence in addition to their self-reports. And 100% of them, every single one, had completed treatment. And I thought, okay, now we need to do a larger study. So I moved out to California, hooked up with UCLA, the Neuropsychiatric Institute, and we conducted a randomized controlled trial with 121 subjects. what was nice about this particular methodology is that I'd been training clinicians in it also who were psychotherapists with this other complicated equipment. And it was working really well with depression, anxiety, PTSD, and things of that nature. And addicts have a lot of cognitive issues as well, attentional problems. They have 47% have head injuries. And so it's a great population to test a methodology out that has an effect on lots of different variables. So we did that, and we published those results in 2005 in the American Journal of Drug and Alcohol Abuse. We had it accepted with the Lancet, but they sent it out for peer review to quantitative EEG people, and they said, well, this is no neurofeedback can happen if you're not doing a quantitative EEG first, and they rejected it. So our field probably could have been ahead by about 10 years if that had gone through. Lancet is one of the most prestigious medical journals in the world. So why I created BrainPaint was that it was complicated to look at the methodology in these papers and then teach people this complicated thing to making all these decisions and things like that. So I automated that whole process. And whenever new studies come out, I build them into BrainPaint. Dr. Paul probably doesn't know this even, but we have a brain-heart coherence protocol also built into BrainPaint. We can do the slow cortical potential training. We can do everything you can imagine with it. We have a progressive disclosure policy, but what we're going to be showing you today is a method in how to get results with about 80% of people who will come through your door. I'm going to do a few things first before we get into teaching how to wire people up and to conduct a session. I'm going to give you a simple language to explain EEG biofeedback with. We'll be the evaluation tool very briefly. We're going to cover measurable goals, but if you start using BrainPaint, we'll get really specific in that because it's a really important thing. Because the training is profound in terms of results, but it's really subtle. It's not like you take a pill and suddenly you're feeling amazing. It's a progressive issue. So it's not uncommon that if people are having panic attacks 6 or 8 times a week, when those panic attacks are gone, they'll go, well, what did that have to do with those wires you're putting on my head for the last few weeks? It's like, well, what else did you do? Nothing, but I wasn't feeling calm while I was doing the training, and it's hard for them to draw the connection to it. The training is a lot like learning how to snowboard or how to ride a bike. It's a developmental type of learning that's progressive, and it takes about 6 hours for your brain to start adjusting. 3 hours, which is about 6 half-hour sessions. So it's like a session, someone comes in for a week, it'd be kind of like, a lot like if you were learning to practice snowboarding, standing on this slippery board, on this slippery hill, and you'd spend most of that half hour on your butt. The sessions are a lot like that also, and that's kind of a good thing to kind of wrap our brain around. But after about between 5 and 8 of these, our brain then starts to develop more control over the underlying states that are impeding with our quality of life. And so the 3 things that are necessary to replicate our results are to know how to use the assessment tool, how do we place sensors on people's heads, and what's a simple language that we can use to explain it to clients. Those are it. And so what it does is it can help us feel better, it can help us think better, and it can help us do things better. Another fascinating thing where either I am really, 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 really lucky, or this has a profound effect on sports. Every sports team I've ever worked with or even trained people to use this particular technology in have always won medals in Olympics, gold cups, and professional tournaments. It hasn't done anything for me in my frisbee golf, which I suck terribly at. But if I had somewhat of a pro-ish level, I would excel. So we've helped the Italian soccer team the year they won the Gold Cup. They'd practiced with this methodology. The All Blacks the year they won the Gold Cup in rugby. The Canadian women's soccer team, the last 2 seasons that they practiced for the Olympics, they won bronze medals. Hannah Teeter when she won a silver medal. Coco Zuccarello, Kelly, I think his name is, who just won the medal in the X Games. He'd been declining since 2013. He did 12 sessions, ended up winning a bronze. Every single sports individual or team we've ever worked with has won medals and things of that nature as well. So the research results, these are them in a nutshell. This is that original study in 2005. This has now been replicated 6 times by other universities, independently replicated. Currently, SAMHSA is considering making this a recommended treatment. We're in the process of been emailing with them back and forth throughout a recommended treatment for addictions, that is. So we had significant effects on 7 of the 10 scales of the MMPI in our experimental group, not the control group. Those are in and above the results they'd made. With cognition, with the variables of attention, we had significant improvements in all of the abnormal variables of attention in the experimental group over here, with impulsivity and inattention as well. And retention, this is what pays the bills for this. Currently, until it's a recommended treatment by our government, their insurance companies won't cover it. So how the addiction centers make their money back, essentially, is not through insurance billing, but by nearly doubling their client retention. The clients who do this, we reduce people leaving treatment against medical advice by 67%, and their average length of stay increases by 47%. And among the treatment centers where everybody is getting it, there seems to be a phenomenon you don't want in your research projects called the Hawthorne effect. There's like this cross-pollination of results where the results get amplified if everybody is receiving like an experimental treatment. It's not an experiment though, but in those treatment centers, kind of like the Native American program, they're having 100% of people completing treatment when everyone is doing a session every day. Another thing that we couldn't talk about with the SAMHSA folks is that we've been doing this in addiction treatment centers in the last 10 years, and there's only one person that possibly may have died a relapse-related death who's done 12 or more sessions. They can't begin to count the number of people in the treatment centers where it's not mandatory, where people have done 4 or 5 sessions or 1 to see if they liked it. They can't begin to count the number of people who've died in the last 10 years. But after interviewing our programs who've seen like over 14,000 clients so far, they cannot identify. There's only one that may have died a relapse-related death who's done 12 or more sessions. So it almost seems like we have a way of potentially eliminating relapse-related deaths, which is a huge epidemic right now. So yeah, okay. These are the abstinence rates, around 70% consistently in all studies. Here's another study last year that UCLA and UNC published on just the attentional aspects of the training, where they did training in 1.5 weeks. They did intensive training of 2 sessions a day, 5 days a week, and they normalized the variables of attention in an ADHD subset of an addiction population, which paves the way for doing really intensive work with people with attentional problems. And American Academy of Pediatrics ranks neurofeedback back in 2012 as being a best practice. So what it does is, early on, someone was talking about this default mode network. It's a resting state network. There are other parts of our brain that are involved with our arousal system. What I mean by arousal is when the least aroused we are is when we're completely asleep at night. And the most aroused we are is if we're in a really intense tennis match or, God forbid, dodging bullets. Our brain is on this other end of very high arousal. Well, there's 3 primary root causes. If you look at the DSM-4, or 5, TR, I believe it is now, every diagnosis, or nearly every diagnosis, there's 3 primary roots. There's underactivation, where our brain is sort of running too slow. It doesn't know how to get going. There's overactivation with some of these people, it's like they're overcaffeinated. They're too awake, and they're too jittery and jumpy, and they can't slow down. And then the third root cause of issues are a hyper-reactivity. This is what I call reactionary forms of anxiety. This is like an anxiety that started as a result of things in the external world and come up primarily in reaction to things in the external world. So like an example of that would be like if this particular brain network called the default mode network is not activating enough, and I didn't drink enough caffeine and I had a frown on my face and I walked by you with a frown on my face, your brain would, rather than taking in reality, it's like, hey, Bill, you all right? Your brain would be like, Bill doesn't like me. And it's because what I said 2 weeks ago in that group. And I don't like Bill either. Or I have to be really, really nice to Bill so that he likes me. Or we trip out over things like that with these kinds of insecurities when that particular brain network isn't activating enough. So what we're able to do with this assessment process I'll be teaching you to use today is we can identify to what extent is one's brain running too slow, to what extent is it running too fast, or to what extent might we need to give them an exercise in changing how they're reacting to things in the external world. And here's a fascinating study. There's actually been about 5 of these now where they're doing one of these, what we call alpha suppression session at PZ. PZ is over the back middle part of our brain. It's over what's called the precuneus. It's the primary control center of this default mode network. And when we teach alpha to drop over that, which our software does, it causes that brain network to further activate. And now researchers are finding that even one session of alpha downtraining, they do a pre-fMRI, and then they do one alpha suppression session, they do a post-fMRI. They go, wow, we can turn a particular brain network on with this without drugs. And the thing about drugs are, unfortunately, drugs affect our whole brain. Our brain is very similar. Brain cells are very similar molecularly. They're all molecularly very similar. So you can't really target a specific brain network. So this is what people have been trying to do with drugs for a very long time, is how do we address these arousal systems, or these resting state networks, they're called. And so these are some results that we get. We collect metadata on every session that's run everywhere in the planet. This is from a couple years ago. We haven't recompiled this recently. But regardless of what it is that people are coming for, after 2 sessions, there are about 45% of them will be reporting some gains. And in my experience, it's usually not much to write home about after 2 sessions. It's like, maybe this is a little better, maybe that's a little better. There's some wishful thinking, probably some placebo-like effects in that as well. But it's nothing, I never get, of course, once in a while, we get very excited about that. If it's night terrors and PTSD, it tends to be pretty significant. But with most things, it's really, I wouldn't be too excited by that. But after 5 sessions, when they came in for their 6th, 65% of people start reporting benefits. And typically there, they've broken a record. What we do is we create measurable goals where we're looking at what are you doing EEG biofeedback for that's most attracting from the quality of your life. Okay, and where is that issue showing up most, where are the worst aspects of this issue showing up most predictably? And then how often is there a symptom of that that we could see, like on a video camera, if there were no words? How often would we see you holding your chest, like having a panic attack? How often would we see you crying? Things of that nature. Or how many times would we see you yelling or pounding on your dashboard in your car, or things of that nature? So we get sort of a frequency and duration. We don't get into intensity with this because that's really complicated. You can't really quantify that really well. But frequency and duration of symptoms make it very quantifiable. And we find that when clinicians do that, that also has a big effect on client retention, because then people can see the changes and they're very black and white. All right, the easiest thing we help people with, these are nightmares and night terrors. This was with 222 subjects in here, that 62% after 2 sessions tends to be quite positive. There's a study that Fort Bliss just completed with active duty soldiers with night terrors and nightmares and sleep disorders. Within 4 sessions, everyone in the whole study no longer had nightmares or night terrors after as few as 4 sessions. It's the most responsive population we have. Oddly enough, in my opinion, nightmares aren't so related to trauma as they are more organic effects. When people's brains are very underactivated, they'll tend to have more nightmares at night, and during the day they have what I call daymares. They'll have, people, almost everybody with major depressive symptoms where they're very slow and sleepy and weepy. They have nightmares at night. They have attentional problems typically, and during the day, their brains go into these kind of sad states. So the brain's trying to increase arousal by worrying and obsessing and things of that nature. I would say our brain it's been talked about quite a bit throughout the conference. Our brain does a lot of things thinking it's being our friend, sometimes when it's not so much. There's an excellent book on that topic. It's called The Accidental Mind. That's all about evolution and how our brain kind of, in evolution, it's like a terrible computer programmer that just creates a bunch of patches whenever there's a problem. Our brain's developmental process is a lot like that. It works great, but when it gets off track, it doesn't do so well. PTSD is the second most responsive population we work with as well. We're here after 55% of people after 2 sessions are reporting some significant benefits, and it goes up to about 84% after 20 sessions. I'm sorry, 89%. And most of the other populations are very similar. This is people with major depressive symptoms, 1,500 of them. It's real similar, nothing to really get excited about after 2 sessions, but after 5 and beyond. ADHD is another really popular population. Asperger's and autism. This is odd. I don't really know how to interpret this data, but they appear to respond more slowly than the average population. But among our clinicians who check in weekly on our Tuesday conference calls, they consistently see pretty similar results to their other populations. So one of the factor might be with this population, some clinicians might not be as responsible perhaps to get them to be still enough in sessions. There's a whole conditioning process that we teach people to get everybody to be meek as lambs within 3 sessions. But if you're not using that technique and somebody's moving around a lot, they're going to have very limited results and they'll be responding much more slowly. Because as you're in motion, there's no feedback actually happening. Okay, insomnia, okay. Very good. So brainwaves are just electric noise from the computer working. They're exactly like if we put our EEG sensors on a laptop and we're hitting different buttons and running different programs, it would make a different EEG signature. So the EEG is not the function. It's a reflection of the function. And one interesting thing about that is that a lot of people spend a lot of time trying to find where is the problem in the brain, and we need to train over that spot where the problem is. No, we don't, because the problem is often primarily related to arousal levels, regardless of the cause of the problem. And when we can teach the brain, when we train over a specific brain network that can teach the brain to speed up a little, to slow down a little, or to stop hyperreactivity, that has a big effect on a lot of issues. Head injuries, for example, are extremely responsive to this work, and probably even the Muse technology as well. Just training over someone's forehead would most likely have some significant improvements with people with head injuries, just training over one spot, because that population, you can put a sensor anywhere and train almost any brainwave and something will improve. The worse the head injury, the more likely they are, in fact, to make some progress. But here, we're able to train over some specific areas that are known to produce very consistent results. But the brain waves are related to these states. So I'm going to go ahead a little bit here. The slowest brain wave we have is delta. And you can think of this as, for certain things that we're doing, we want to be in certain brain states. So if we're trying to sleep, we don't want to be having brain waves that are like we're reading. Or if we're trying to read, we wouldn't want to be having brain waves that are like we're sleeping. And that's a problem. A lot of people's brains get stuck in these positive feedback loops that tend to be self-reinforcing. You know what I mean? A positive feedback loop, an example would be a microphone that's set too sensitive and it starts squealing in on itself. And then until somebody gets in there and adjusts the volume, it's going to keep squealing. Well, a lot of people's brains, once it gets into these loops, they tend to be self-reinforcing. Like Candace Pert, who quoted someone, I forget who said, you know, the neurons that fire together wire together. So problems tend to be self-reinforcing. And what we're doing is we're giving negative feedback. So the brain is stuck in this positive feedback loop, and we're then giving it information on some different states. And the nature of our brain is anything that you can give it real-time feedback on, it will automatically self-regulate. It automatically starts to self-improve. A really awesome example of that is 2 years ago, there's a biofeedback device called BrainPort that just received FDA approval for curing blindness with 100% efficacy. This is people without even eyeballs. All they do, they put a video camera on their head and they cut the wires that would otherwise go to a screen that they can't see because they don't have eyeballs. They put those wires, thank you. They put the wires on their tongue, and their brain, within a half hour, nothing happens. Nothing at all happens. Their brain's getting information, but it hasn't learned anything. But within 3 hours of training, their brain self-regulates. Their brain figures it out, no matter what it is. When you give, if any variable is involved in your real-time functionality, you can give your brain some real-time information on. Our brain will automatically figure it out and self-improve. They've been doing some other studies with that with fMRIs now, with what they call passive biofeedback, where they don't even tell people that they're getting any feedback. It's just when their right amygdala deactivates, a sound starts to happen, and then they watch, and across sessions, their right amygdala deactivates. And they go, so what did that have? What's going on here? And then later they tell them that. But being that that's involved with increasing functionality, the brain will automatically figure that out and learn how to self-improve. So some other brain waves here. So the one thing we're going to be demonstrating that is sort of the most fascinating piece of this is this type of training called alpha theta training. This particular type of training is necessary for these reactionary forms of anxiety that I'm talking about, where to train our brain to access some states where we're just experiencing everything more as it is. At one level, we don't, well, let's say when it comes to negative experiences in the world, there's pain, like loss and things like that, or somebody stomps on your toe, you're in pain. But about 99% of the upsets that we have are related to, it shouldn't be like this, or I hope it's going to go like that. And these little fantasies that we create around the world that give us this kind of false sense of security or what have you. Well, one of the things with this alpha theta training that's really powerful is when our brain learns to become more interactive versus reactive, we end up, our world expands. We start seeing a lot more opportunities than we could previously. That certain things that are driving us, that are out of insecurities and things of that nature, get replaced with a different drive, out of more of a sense of belonging or a sense of contribution or being of value to others. We tend to do the same things a lot of times, though, that, like in terms of our life's purpose, but we can just be driven by more comfortable desires. But the alpha theta training I find to be one of the most powerful. There's another type of training we have built into here that's very experimental. We've not done any studies with it, but it's called delta training. When you train your brain to increase this sleep-like brainwave, when you're not actually sleeping, you end up sort of waking up to what a dream this really is. You get this really broad picture of life and you in this kind of different game kind of a thing. But the alpha theta training is an approximation of that. What it does is it trains our brain to increase a particular threshold where we would go into a survival mode needlessly. And the results of that are relationships tend to get a lot better also because we tend to attract people that have similar buttons to us and things like that. And they push your button, you push theirs, and the two of you kind of escalate here over and over and over again. Well, if one of you trains your brain to become more interactive in that space and they're no longer going that place, you would just sit there arguing with yourself essentially. So there's a lot of things that can happen with the alpha theta training. So just give me 1 second here. Well, one thing that's really important also when we're doing this work is when you're first getting started with it, it's like we can get really focused. It's okay, what button do I press and what do I do with this and how do I adjust that? And your client's kind of sitting there. We've lost some connection with the client. It's an easy thing to do. And the clients will tend to feel that when we have it. And clients don't care about results. I mean, I see this occasionally. We'll get a clinician who may not have that great of a bedside manner. But when they're using the technique exactly as we recommend, the results are identical to everybody else. But their client retention is a fraction of what it would be with other people. So the clients are getting results, but they're not coming anymore because of a certain, the relationship is more important to them than the results that they're getting. So being aware of the equipment and just consciously putting a connection on your client is a good exercise. And when we're going through the practicum today, I'd like us all to do that. At one point, when we're going to be doing an alpha theta session, I'd like us all to be connecting with the client who's receiving the session energetically as well. All right, so there are desirable and undesirable brainwaves when we're doing brainwave training. For the state at hand, so when you read the literature on alpha, you'll find almost everything will say, oh, the larger your alpha is, the more at peace and the more freedom you are. Advanced meditators, consistently in studies produce very large amplitudes of alpha when they're in this kind of state of oneness and things of that nature. And yes, they are. That's a fact. Alpha is an idle rhythm. Less work, more alpha, regardless of the cause. If your reptilian brain is taken over and you're now feeling like your dad's going to disapprove of you if you lose this tennis match or something like that, your brain is also going to start producing large alpha when the reptilian brain takes over. The outer neocortex that you could make decisions and things of that nature will go more idle. And so a lot of people will talk about, that there's a good brainwave and a bad brainwave, but unfortunately, when it comes to the research and looking at how brainwaves change, when you're looking at these linear measures, which a lot of folks do, you're not going to find significant changes in them because there's dozens of things that will affect our brainwave, like what time it is of the day, how long it's been since we've eaten, how warm we are, how cold we are, how anxious we are, how much we slept the night before, if you have a European cell phone 3 feet away from you. I could go on and on and on and on about things that will affect the EEG. Fortunately, our brain is the real miracle machine with this work, that we can give it information on these very noisy signals, and it can figure out what to do when we give it certain parameters to work with. So one of the things, though, that's critical to the process is that there's a lot of ways that you could think that you're doing neurofeedback when you're really not. And the most common way of doing that is if you're not checking the conductivity. There's one test that in our oral exam that you would fail if you failed to check these lights on the brainwave amplifier to confirm that you have an adequate connection before you hit this start protocol button. But that's the most common way that people can make an error with the training process. Because then once we have a good signal coming into the equipment, we can filter it out And we have these things that are called rewards and inhibits. With BrainPaint, this is all under the hood. You don't have to be monitoring this. It automates this process. But a reward is essentially with the desirable brainwaves that we're training. When they go above a certain threshold, some sounds happen, some visual information happens on the screen, and our brain gets some real specific information about that. The inhibits are the undesirable brainwaves. So during the alpha theta sessions, if you start thinking a lot and getting more in your head or trying to make the sounds do different things, these higher frequencies come up and the sounds stop. And those are inhibitory conditions. And then when you're moving into more of the desirable states, the sounds begin to happen. So there's two types of training that we offer. You can think of it quite simply as there's eyes open and eyes closed training. The alpha theta sessions have to be done with the eyes closed. You can't really access a very deep state if your eyes are open. And what we do with the alpha theta sessions is we play this guided visualization. I'll say, now bring to mind some future event that you'll be encountering that might be somewhat anxiety producing for you, and just tell me okay when that comes to mind. And so let's say, for example, if I had a fear of flying, I'd think of flying home next Wednesday. Okay, I say out loud. And then the machine would say, now think of yourself leaving this event, having the thought occur to you, and easy. So I would just think of myself as going home, and the thought occurred to me, oh, it was an easy flight. And I'd say, okay. And then it asks me to set an intention for that to happen. And then it asks me to think of some positive or neutral experience, if I can, for the next minute. And then just let your mind daydream. It'll say, and it'll also say, if you meditate, don't meditate. That's an important thing, because if you meditate during those alpha theta sessions, you'll have the exact same experience as if you were at home in your easy chair meditating. That's a conditioned, your brain would have a conditioned response to that. So the alpha theta sessions then teach your brain to get into these real deep states where you're just above sleep. You're not asleep, but you're not fully awake. And in that state, you'd have some thoughts about flying or some dream-like experiences. But while you're so calm, you can't have the reaction, the anxious reaction to it. And so for some of you who've looked up classical conditioning, how do you extinguish a conditioned effect, is you introduce somehow the conditioned stimulus, which would be the flying, without and not introduce a conditioned response, which is the fear. That sets up the brain to start to put out these little neurons in the amygdala, a part of our brain that stores fear-like memories. They start going out. And as few as one session when people have an experience like that, that will tend to have an impact on that. Most people don't tend to even remember that that happened, kind of like you don't remember all of your dreams as well. But whether they remember it or not isn't necessary. We still see the same kinds of symptom reduction with that type of a thing. So that's an example. There's different types of feedback as well. There are game-based systems, which I used for years. I thought, because I used to work with a lot of kids, and I thought, boy, kids love games. They do love games, but they also love to have a lot of control over the games. But they don't over neurofeedback. They can't think, ship up, ship down, left, right, fly, shoot. They can't do any of that. DARPA's been experimenting that for over 40 years, and they've given up trying to create a brain-computer interface. They can spell one word per minute with our brainwaves. It's the best we've been able to do with volitional control over the EEG. So with our feedback, with the eyes open training, we produce images on the screen that will show the shape of the waveforms to communicate on a deeper level what our brain is doing in real time. We produce about 40 of these per second, or their brain does, based on the shape information of their EEG. Everything that they think, feel, and experience changes the motion, the color, the texture, the rotation. And what's nice about fractals is it's kind of limitless of all the variables that we can give information on. And it's also the way that our brain really works. That there are these things, how many of you have studied complex theory in here? Okay, one of you. All right, I won't get into all of that. But there's a particular thing that when you have a system with 3 or more parts that are all influencing each other, they tend to find these things called points of criticality. that are at their optimum levels, and the fractals will produce that on various brain waves that that we're working with. One can't typically look at the picture and go, oh, this means this and this means that with the fractals. I've been kind of misled a number of times. I have 3 clients with one particular thing. It'll seem like, angry people make prettier pictures. But when you do the statistics and things like that, that stuff doesn't tend to hold out. But I'm also not very visually oriented. I'm very auditory. And others may be able to see some things in these that I don't know. But I can hear if somebody's getting a little bit warm in the session, if they're getting anxious, if they're getting sleepy, if I can hear all kinds of things from the sounds that their brain is producing during part of the feedback. Again, during eyes open and eyes closed training. And during the eyes open work, I'll cover all that actually when we get into the practical. I'm going to be walking you through all step by step in operating the equipment. So here's another type of assessment that people use called quantitative EEGs. They typically don't use, that's with 256 sensors, but that's one type of assessment that people do. There's been one comparison study where they've compared what they call this model that we have built into BrainPaint. It's called the Scott and Kaiser modification of biofeedback. There's one comparison study that compared it with a polysubstance abusing population. Didn't find that methodology to work better than ours, but it was quite stifling. In fact, it's very difficult to even get research associates to learn how to use that methodology. The learning curve is about 2 years. The equipment's about $20,000. And the reason that I created BrainPaint was to reduce that expensive barrier that it is to get into this particular field and make it less expensive. So we covered this already, that there is desirable and undesirable brain waves for the tasks at hand. We give our brains exercises with it. It's kind of like riding a bike. Where it's a developmental learning process. It's not like you have to remember something. You don't have to consciously understand things. The youngest I've heard of anyone doing this with were a set of twins who were 7 months old with intractable seizures. They were slated for split brain surgeries to stop the seizures so they wouldn't die. Within a handful of sessions, they were seizure-free. It's been over a year. They've not returned. So in a case like that, the parents just hold the children and physically restrain them so they're not moving and twitching and doing all the things babies or little children do. But so one doesn't have to understand it. The original research with this was done with cats, where I wasn't involved in it. I love cats. I've probably watched more hours of cat videos than all of you combined. But they trained them with one of the brainwaves that we work with BrainPaint. And it made them immune to the toxic effects of hydrazine gas. One of the things that I'm thinking I would love to see some pre and post testing on inflammatory markers. We have one naturopath who's doing pre and post measures of pregnenolone, which is, I don't know a whole lot about this aspect of what I'm talking about right now. But what he's told me is that pregnenolone increases significantly when people have undergone BrainPaint training. And one of the effects of that has a big effect on our brain's ability to mediate our blood-brain barrier, to allow, when the blood-brain barrier is less porous, less toxins can get in. So I'm thinking, going back to that cat research back in the late 60s, that probably is what happened with them, that the pregnenolone caused the hydrazine gas. It prevented as much of it for the cats who received the neurofeedback from being toxic, compared to the other cats who didn't do it, either had seizures and or died, but the cats that did the neurofeedback didn't appear to even get sick from it. So I'm thinking that's probably another factor. I know that all of the addicts who do this are not staying sober. In our studies, we see about 20 to 25% of them relapsing, but they're not dying when they've done 12 or more of these sessions. And so maybe if it's increasing the pregnenolone, that it's when they do relapse, that it makes them less prone to the toxic effects of the drug that would otherwise kill them in a relapse scenario. But more will be revealed. I would really love to see a study on inflammatory markers as well. I'd love to see a study with an insurance company. Kaiser Permanente has been sending one of our providers clients for the last 4 years. And every client for the last 4 years has been doing a BrainPaint session every day. And so they've had 300 clients that Kaiser has referred to them so far. I would love for them just to do a simple search in the database. What are the expenditures of these 300 clients compared to the expenditures of everyone we sent to other programs that were just like this that didn't receive it? My guess would be the savings would be in the hundreds of thousands of dollars. Blue Cross Blue Shield did a study with just one component of BrainPaint 20 years ago with guided visualizations, where with preoperatives, they had this really crappy quality audio cassette tape they sent to people who were going in for surgery. They listened to this guided visualization. Now think of your body healing. Think of yourself being open to the effects of the surgery. Think of yourself recovering more quickly. Just this really simple, crude guided visualization. They ended up saving, they did over 1,000 clients. They ended up saving an average of about $800 per client with just a guided visualization alone. That was over 20 years ago. 2 years ago, my mother-in-law went in for a real severe open heart surgery and lived, thank God. But she had a little MP3 of that thing from Blue Cross Blue Shield because they're saving a gazillion dollars from that alone. All right, so I am a couple other things here. So, yeah, the eyes open training tends to help with these more issues on the left, these issues that are more sort of organic in nature, like things you were born with, or things that might have happened from like chemical imbalances or hormonal issues or things that run in your family systems. The alpha theta training seems to help more with these things that started in reaction to things in the external world. How you're born with an okay brain and then X, Y, and Z happened outside of your body and your brain got stuck reacting to them. So the alpha theta has to be done with the eyes closed in order for it to be effective. Covered that. We have providers in pretty much every major city throughout the U.S., and we have a few more than that now in Hawaii, more all the time. But if you want to make referrals to the program, if you're not interested in getting started with this yourself, if you don't already have kind of a thriving practice that you're going to look this into, and you wanted to see, if you go to look up Find Neurotherapists, or neurotherapist.info, you can find our providers in your area as well. All right, so I'm open for questions here. If folks have one, yes. It's information. We do this assessment. The software tells. Yes, we'll be pasting sensors on a person's head. Yep, and converting their brainwaves into real-time auditory in all types of training, and visual in some other types of training. And then the brain self-regulates from that information. It's called sensory substitution. That's the same principle with the BrainPort product, where they put the video camera on people's eyes. They're using tingling sensations in their tongue with that type of feedback, and their brain figures out what to do, how to see from that tingling sensation. When they look at the fMRIs, they see that their occipital lobes that process vision start to activate. We're doing that with mental and emotional states, converting that information, substituting the emotional states and mental states into auditory information and visual information.
Sorry, just to follow up, this is really a direct-to-practitioner equipment. It's not anything that's consumer-focused.
No. Is it consumer-focused? Was the question, could a consumer get this and try it on themselves? Oh. I tried to make it that way. Yeah, I just repeated the question, but so okay.
This is hello.
Hi.
Can you hear me? So
I can.
So no, it sounds, because of the cost of the equipment, that this is practitioner focused and not something that's consumer oriented.
It's not that expensive. It's only $475 a month. So there is a home use program that we're not in charge of. Another clinician, she's a PhD psychologist who can oversee it. But when I made BrainPaint, I thought it was going to be this off-the-shelf product. People could get it, hook themselves up, do these protocols. I did an experiment with 20 clients who were very biased, wanting me to win, but they were not therapists of any kind, trying to do their own assessment and do the hookup process. And it failed miserably. They couldn't replicate our results. They have to have some interviewing skills and also be trained how to place the sensors, because it's easy to think that you're putting sensors on and you're doing training when you're really not. But good question. Back here, there's one question.
Hi, Ben. What were the monitors, or what did you monitor in improvement in Asperger's?
Joint attention. Oh, so what we monitored with Asperger's is typically like joint attention. You point at something. Normal adults and children about 6 months old will look to whatever you're pointing at and look back at you. Is like a really big milestone of connectivity. We're looking at a particular behavior that appears to be detracting most from the quality of their life. When they're in their teens, often it's behavioral issues of screaming, banging, head banging, rocking, repetitive movements and things of that nature, or the self-soothing things, the intense OCD, the tics that are quite frequent with them, the symptoms that are detracting most from the quality of their life per the parent. We actually measure, we do training. We're not testing necessarily per se, we're training primarily, but every quadrant of the brain. So over the parietal lobes, the temporal lobes, the prefrontal cortex, all of them, there's various protocols that we might use. What we find with one protocol fits all, there's a lot of studies that looked at just training, CZ, SMR with what they call a theta beta ratios. All of those studies where there's just one placement, you tend to get a 33% success rate, where a third of people will do okay with a one placement type protocol.
I have two questions. First one, following your analogy of riding a bike as a training, how do you handle the falling while they are training, riding the bike?
Yeah, good question. There are some negative side effects that can happen with the training. And we have subsequent questions after the first session that is sort of a catch-all of all of them. Because some of the information is subjective when we start. And based on that, some people their brain might get slowed down a little bit. Well, then we ask specific questions that will elicit to what extent did your brain slow down too much. And then the software will make a recommendation to change to speed their brain up a little bit. But yeah. Good question.
Okay. So maybe a little bit more specific, the question in terms of, have you handled any or tested it on sex traffic victims?
I've worked with a tremendous amount of people with severe trauma and DID, ritualistic abuse and things of that nature. Myself specifically with sex trafficking, no. We have, though, about 500 providers who work with every population you could possibly imagine. Some of them do work specifically with them. And by and large, there isn't a lot very different about different populations. There's one population where there's a different thing that we do. It's people with a bipolar disorder. We can't do any of these, we can't start them out with any of these protocols that we're training, or they have these very odd, unpredictable reactions. But other than that, there's not like a population that you have to do some specific things to, because there's still one of these three primary root issues that at the core: underactivation, overactivation, or trauma, essentially, PTSD-like reactions. There's a spiritual component of this all as well that the neurofeedback doesn't touch. It reduces resistance to people going there, going to uncharted territory in healing-type spiritual work, like addictions. It doesn't do anything for addicts if it's not combined with an already effective treatment approach. People can bring in their 40-year-old potheads all day saying, fix them. It's never going to do anything. If they have if they have the gene for addiction, it's not going to touch it. It'll reduce that. Or people with character disorders. It's awesome for the trauma, But that alone isn't going to improve the quality of their life. Once they stop their traumatic cycles of abuse, then they're more open to adopting a new way of operating, a new operating system, and that's where the therapy and the work comes in. So the clinicians who are working with those populations are like, oh my God, how did I ever work with these populations before I started doing this? Because it's kind of like working with a handicap. Yeah.
Thank you.
There's one closer to you, and then Justin.
So just thank you for your presentations, beautiful. You mentioned about bipolar, and I'm really curious when you mentioned specific protocol. Can you speak on that, please?
I can a little bit. It would be days to cover what it's doing. But essentially, in a nutshell, their brain doesn't need to speed up, it doesn't need to slow down, and it doesn't need to stop reactions to things in the external world, at least initially. Their brain needs more help in stabilizing states. So we're giving their brain information on essentially like turbulence. There's mathematic formulas that will measure turbulence in complex adaptive systems. And we're essentially teaching their brain how to stabilize states. And the more severe they are with this particular approach, the quicker it tends to work. But if it's real mild cases or it's kind of suspect, that particular approach doesn't have a whole lot of effect on them. But yeah. Justin, yeah.
Yes, sir. Thank you for being here. And my question would be based on amplitude and coherence within the mind. How is a neurological deficit going to take effect with your BrainPaint program?
Yep. Some of our protocols actually will give some feedback on hyper or hypocoherence. It'll look at an individual's levels of that as one of many markers. And we, with this game you'll be all playing, it'll be capturing your EEG, and then it would send it to our lab, and we analyze it and send you back in 2 business days a protocol based on that. So we'd be looking at what was your brain doing when you're performing at your best, and what was your brain doing when you're performing at your worst. And we look at a lot of various parameters, and we would then be giving you feedback on the parameters of when you're performing at your best versus your worst, and what we call the rewards for the best and the inhibits for the worst.
Thank you.
Yeah.
Yeah, thank you for your presentation.
Okay.
You talked about alpha delta training. What is it and what is it like used for? If you can just give a small idea about that.
Good question.
Thank you.
Well, there's alpha theta training, which we always sort of do together. We train with the relationship between alpha and theta. But the delta training is a thing where we just give feedback on this sleep-like brainwave, and it isn't appropriate for a lot of people. So if someone's system is already very underactivated, they're kind of slow, sleepy, and things like that, it won't have much of an effect. Or if someone hasn't done a lot of sort of inward work with the delta training, and they end up having like a vision of, oh, all life is me hiding Easter eggs and then forgetting it and then going on an Easter egg hunt. And when I find an Easter egg, I go, oh boy, good, Billy, you found an Easter egg. To some extent, when people see that is going on to some extent, they can get very depressed. Going, that's all this is? It's just an adventure? So the delta training is good in the sense for people who've done a lot of meditation and they've kind of explored who they are, what they are, and they're okay with that. When you start doing the delta training, you can then kind of get these broader views of yourself in the world and what a dream life is. So you can get these perspectives of, let's say, you know, if I'm not in a great spiritual space and I'm in line and the clerk in the grocery store is not in a great spiritual space and come on, can't you get your money ready, everybody, before we get in? And I'm like, oh, I'm in her dream now. If I'm in a bad place, I'm in her dream and I'm going, oh, let's see, do I have my money in this pocket? no, I guess I don't. I'm like participating in her dream and I wouldn't even know it. So the delta training can kind of zoom out and you start seeing how you're playing these games and all these scenarios and you're adding to dysfunction, or you start seeing that you're not as virtuous as you would like to believe that you are. It can be disconcerting on some levels. So the delta training is a thing that I'll turn people on to, tend to be kind of explorers, you know, people who are functioning on all cylinders in work, play, and love, typically will like that eventually. But there's no sort of clinical indication for doing that with anybody per se. But I'll introduce it to some of my more explorer-like clients or clinicians who explore a lot with the training. They want to see what different protocols do, and they have the neurofactory in case they did get depressed. They could tune themselves up to get in. But also, the negative side effects will only last 3 days anyway, so you can't permanently hurt anybody with neurofeedback. Also, I should probably put that out there, so I'm talking about negative side effects and things like that. Yeah. All right, that is it. So let's. Oh, okay.
Sorry, you were mentioning about the side effects. Did you suggest that people lower medications at all because of, you know, impact on dopamine, serotonin, things like that?
Good question. Some people can start to become over-medicated while they're doing this, and you just handle it. I would recommend handling it like anyone, of course. If we're not the prescribing physician, it's illegal and unethical for us to make recommendations to them about their drugs, but you'd handle it like you would anybody who appeared to be over-medicated. You'd say you could bring this up with your psychiatrist or not, that you're doing this, but if you're appearing over-medicated, talk to your doctor about that. And they typically reduce things and they start getting good. Like, that's one thing, is a good protocol like never turns bad. So if you see somebody starting to lose that lust for life and like, oh, my daughter was accepted into Harvard and I had to fake like I was excited about it. It's like, okay, that's a classic symptom of being over-medicated. Go see your doc.
And love the name of BrainPaint. I'm just curious because of the creativity of it. Have you ever thought about printing or providing something with their work of art that they've developed from their brain as a graduation present, or you've achieved this? Or I'm just curious what you've done from an artistic standpoint.
Yeah, good question. We do that in our nonprofit clinic because there we have a lot more time and they're not paying customers and things like that. So we tend to do that more. But people get totally obsessed with their images, particularly when you've rendered them out. When we're doing the training, they're all kind of grainy and stuff. When you save them, they look like photographs of other universes. But we do that, but people will get obsessed. If you open that Pandora's box, you're like, oh, I want a bigger picture. I want this one. I want that one. And pretty soon you're just looking at pictures. You're not doing any brain training anymore. But we have done it. We do fundraisers sometimes where people will, buy tickets at this thing for, this treatment center, and then all the proceeds go to it. Like they'll buy like 5 pictures or things like that. We have an art edition built into the machine that people can get hooked up and for 5 minutes and just make cool pictures and that. So we've done some things with it, but we've not. A lot of people have tried kind of wrapping their heads around marketing them or selling them, and no one's really done that in 10 years so far.
Yes, I want to thank you very much. Very nice presentation. But I'd like to bring you back because many ask questions about treatment. Can I treat this and treat that? And still, again, you are back in this mode of treating condition, okay? If this is possible with neurofeedback, but then you have to keep in mind that you have to work with licensed professional. What I was more interest, but what attracted me to BrainPaint, he spoke all the time about training. And then the evaluation is based more on a questionnaire. And there is this kind of, is the brain in a mode of reactivity or under reactivity, or this is what you kind of identify. And at the end of the day, you get almost results on all the spectrum of condition. So you don't have in some way to worry, is it this kind of problem and this kind of problem, and here I'm treating that specific condition, but you are more training the brain to this better balance. You will agree with that, right?
Yes, yes.
And this is where, if you, again, Neuro Biofeedback certify, this is what you're allowed to do without a license. So keep that in mind, because it's very easy to get back again in this kind of track, you know, where you want to treat this autistic kid, or you want to treat that and treat that. And BrainPaint allow to go in somewhere around that, okay? And this is what is fascinating, because you saw all the statistics and the research, and practicing neurofeedback with brain mapping, it's a long road, okay? Because as you said, you know, you work with this brain mapping, and then from there you try to identify what will be the protocol, and at the end of the day, you don't get even more result than doing what is doing BrainPaint or Morphology Biofeedback. So I want to again underline that because it's very important. Yeah. Thank you.
Yeah, very good point. Thank you. Yeah, we're not treating any medical conditions yet. In fact, when people want to see, well, show me my EEG and how that's changed across sessions, that's actually illegal for us to say, oh yes, this brainwave was here and now it's here. Given that it's not a seizure disorder and we're not a neurologist, only neurologists can say your EEG has changed in this particular way as a result of some treatment for any condition. So yeah, thank you for that, Dr. Paul. That's a very important point, that it's training versus a treatment. Yeah.